It's my pleasure to welcome you to this webinar. This is sponsored by the National Institute for Mathematical and Biological Synthesis. It's based at the University of Tennessee, Knoxville. This institute is supported by the National Science Foundation and by the university, and we're very, very pleased to bring you this webinar today. I am your moderator. My name is Louis Gross, and I am the director of NIMBIOS, the National Institute. I also am a professor in ecology and evolutionary biology and mathematics here, and we really are pleased to have you join us for this webinar, which is the first in a series that we will be hosting. The way to interact today is through the question and answer part of this. So at the bottom of your screen, you will see a Q&A. And if you click on that, it will bring up a window. In that window, you can type into the lower box there a question, whatever question that you'd like to pose there. After you do that, the question will appear in the upper part of the box. And you will also see that other questions that have been typed by others, you can vote them up and up with a little hands up, thumbs up. If you'd like to move that question higher up on the list, we will analyze and respond to these questions at the end of the webinar. So that's how we'll be interacting today. A number of people are using the chat feature. We will likely not be monitoring the chat. We will be monitoring the question and answer part of this. So please do type your questions in there whenever you feel appropriate. The next upcoming webinar is being held next Tuesday at the same time. The title is Costs and Benefits of Defending Against Viral Infection. In this case, it's Lessons from Natural Ecosystems, and our speaker then is David Talmy, who's on our faculty in microbiology here at the University of Tennessee, is an expert on microbial systems, particularly in marine systems, but we'll be able to explain what we know about viral infections from a long series of analysis in natural systems over many millennia. Our speaker today, however, is Nina Fefferman, and Nina is one of the world's leading experts on not just infectious disease, but its connections to human social systems. She's published and carried out a wide variety of research in response to many of the previous pandemics, and we're very pleased that she has taken the time to do this. Nina is not only a faculty member in ecology and evolutionary biology and mathematics, she also directs at the University of Tennessee the Mathematical Modeling Consulting Center, and she's also a one of the directors of our One Health initiative here at the University of Tennessee. So Nina will be responding to questions at the end of this. We intend for this to last about an hour, at most an hour and a half, depending upon how many questions we have. So thank you very much for your participation. Nina, it's all yours.
Whew. So first of all, thank you everyone for joining us. I'm really excited to talk to you. Thank you, Lou, for the introduction, and to NIMBIOS for hosting the webinar series. So today we're gonna try and do three basic things, and I'm gonna try and talk at a really general level. So hopefully, if you're already a mathematical modeler modeling epidemics, hello sisters and brothers, but you're probably going to be bored. So I'm going to try and explain this at an audience level where maybe if you got through 7th or 8th grade math, that should be all you need for today. And hopefully anywhere where I screw up and use jargon, someone will ask a question and I'll be able to clarify at the end. So our objectives for today, first we're going to understand how math models help us to analyze and predict outbreaks. We're also going to gain some familiarity with concepts that you might have been reading about in the news. So there's been a lot of press coverage around pandemics and pandemic modeling. That has relied on some of the metrics that we as modelers play with all the time, but sometimes it takes for granted that a one-line explanation can communicate well to a public audience, and I don't know that I believe that, so we're going to spend a little bit of time talking about what some of those common concepts are and what they mean. And then lastly, we're going to talk about how these kinds of models can be used to design public health policy and help inform the kinds of decisions that we want leaders to make for us to keep us all healthy. Okay, so that said, I'm going to get right into it. So today we're talking about the role of applied math in real-time pandemic response and how basic disease models work. So I want to start, before we even get into talking about epidemics, I want to start about what mathematical modelers do, because we're not actually the typical mathematicians. So in the world of mathematics, there are pure mathematicians, and pure mathematicians think about abstract objects of logic. And there can be equations or there can be algorithms, but fundamentally, it's pure mathematics is beautifully about elegant thinking of what the logical consequences of particular assumptions turn out to be. And those can be very surprising and very complicated and beautiful. And then when we move into applied mathematics as a field, applied mathematics has the same sentiment and tools as pure mathematics, but it takes its inspiration for which questions are interesting from challenges in the real world. But still, it takes those abstractions of those challenges and then it turns them into mathematical objects, and the analysis is still driven by the mathematical internal understanding of the logic. What modelers do, which is a subspecialty really in applied mathematics, is that not only do we start with a real world problem, but we stay in the mindset of the real world, even though we are still being mathematicians and we're still thinking abstractly and using all of the tools of mathematics to analyze our system. So we start with some real world problem. And in the real world, of course, everything is very complicated and there are tons of interactions, and those interactions aren't simple. They can be, if there's a little bit of this, then it only has a little bit of effect, but if there's a little bit more, it has a huge effect. Or it doesn't do anything by itself, but if there's three other things that are all perfect, then it does everything. And so those interactions are complicated to capture in the real world. There are zillions of possible factors, right? The kind of catchy, inaccurate, but adorable idea that if a butterfly flaps its wings across the world, it can cause a hurricane, right? You might have to think like, oh God, where are all the butterflies? There are lots of different possible things that you could measure or things that you could observe, and some of them are really meaningful and some of them aren't. But there is sort of that underlying concern, oh God, if I don't measure all of them, how do I know which ones I should have measured? And then there are a lot of things beyond those even that we couldn't possibly measure. So even if you measured everything in the universe in order to try and figure out which things were meaningful, there are lots of things you can't actually measure that could also be meaningful. So the real world, this is my pitch for the real world, is terrible and really noisy and really hard to deal with. And empirical scientists are the people who study the real world. And I have incredible respect for how they try and control for and simplify out a lot of this complexity. But that's not what math modelers do. We don't try and study the empirical systems themselves directly. What we do is we use math to try and explain things. So what we do is we take all of that complexity and we try and distill it into the fundamental logic that describes the systems. So we know that the real world has all of these complexities and has all of these factors and has all of these different things that could be meaningful and we don't know. But what we do then is make this very logical guess, and we reduce the system down to, you can imagine it as a flow chart, but really it's simply the logic of the system. And then we try and turn our logic into equations. So the first step, that abstraction to logic, I like to think of it as becoming a good storyteller. So right, if you want to tell a story to your friends about the world you've experienced, there's a lot of things that you experience while you lived through the thing you're telling as the story that you don't talk about. Maybe there was a guy in the corner with a brown jacket, or a bird flew overhead, or your nose kind of itched. But those things aren't necessarily part of the story that you're telling. So your job as a good storyteller is to go, which parts are the things that my audience needs to know, that I need to know in order to understand the plot of this story and to understand what it is that the storyteller wants to share with me about the story. How do I listen and how do I tell my own stories? And then that's the distillation of logic. And then in order to be able to take that logic and make quantitative calculations, things where we can actually make predictions that say, this is going to be 3 times bigger than that thing, or this is going to be this will always be bigger than that other thing unless this third thing happens. And to make those predictions with numbers, or at very least with representations of numbers, with variables. There are lots of different types of quantitative model methods. So even modelers are already a subset of applied mathematicians. Modelers also use a whole bunch of different tools, and some of us specialize more than others in particular ones. So here's a list of some of the main ones that we use. So linear algebra and some matrix models, difference equations, differential equations, game theory, networks, cellular automata, agent-based models, which are a little bit different still in that those tend to focus more on algorithms than equations, and statistical models, which tend to focus more on trends in data as their own object instead of that logical process. We can ask things about the data itself in those models. The details of what gets done in each of these types of models are different from each other, but the basic idea is the same in all of them. We start with the real world, and then we get the logic from that system, and then we turn it into equations or algorithms, and then from that we are going to try and make predictions. So that's the universe in which we're living together. So now let's talk about outbreaks. So here are some examples of incidence curves in outbreaks. These are graphs of who is getting sick over time during outbreaks of infectious diseases. And we're going to try and use some mathematical modeling to understand these outbreaks together today. So the first one here is measles, which is an infectious disease that's respiratory transmission. Also flu, respiratory transmission. And then we have West Nile virus, which is a disease that's transmitted by the bites of mosquitoes. But you can know, so these are 3 quite different diseases. They cause different sets of symptoms. In one case, you catch it in a very different way. But there's something that if you're trying to find a pattern, you might ask yourself, which is all of them go up and come down. So we can ask ourselves, why do outbreaks end? Is that a story that we can tell ourselves about outbreaks? Can we tell ourselves a story about the nature of infectious disease that tells us why outbreaks have this shape of they go up and then they come back down? Why doesn't everybody always have measles? Why doesn't everybody always have the flu or always have West Nile virus? Or why doesn't it just go up and not everybody gets it, but about, well, I could imagine a universe where 1/3 of the people always have West Nile virus. That would be a terrible universe. None of us would enjoy it. But why doesn't that happen? And so an easy answer for some diseases, like measles, thankfully, is, well, sometimes the outbreaks go away because we develop a medical intervention like a vaccine. And if we give enough people the vaccine, nobody is left around to be able to catch measles. So then we can just force the outbreak to end. We as humans we can exert ourselves over the natural process of that infection. And then there are also diseases where we have vaccines that we can roll out like that. But for example, West Nile is not one of them. And flu in 1918 wasn't one of them. And you can notice that those diseases also had an outbreak, but that outbreak ended. So even if we don't have a vaccine, we see this pattern. So it can't just be that humans are really good at making sure that we can't catch the diseases. Because we can all catch flu. We could all catch West Nile if we're bitten by infected mosquitoes. And if we're not immunized, we can catch measles. And sometimes even if we are immunized, because vaccines are not perfect. But the measles vaccine is really quite good. All right.
Nina?
Yeah.
Nina, it's Lou. Your voice is breaking up a bit. We think it might be the web server, but why don't you try turning off your video just to see if maybe that improves sound?
Sure. Let me figure out how to do that. How's this? Is that better?
We'll try it and see.
Okay, someone let me know. Thank you. Okay, so now I have to get back into somewhere where I can advance slides. There we go. Okay, so let's talk about the abstract logic of the infections together. So what do we know about infectious diseases and how they work? Well, so again, let's start with the real world and have that conversation together, just as humans experiencing the phenomenon of an infection. We know that we've got healthy people who can catch the disease, and they can catch it from sick people who have the disease and are infectious and can transmit. Right? So that's the definition of infectious diseases. We have in the world non-infectious diseases. We have cancer, things like Huntington's that are genetic. We have diseases where they are contamination driven. So if you think of radiation sickness, it may not technically be a disease in the same sense as having a pathogen. But for infectious diseases, healthy people catch disease from sick people. Just as a sanity check, is that better? Can you guys hear me better?
Yes.
Okay, awesome. All right. So we're all on board. Healthy people catch diseases from sick people. All right, so what does that mean? Let's break it down. Let's break the logic down together. What happens to susceptible people in order to catch a disease? Well, first of all, they have to come in contact with a sick person. If they don't come in contact with a sick person, they can't catch the disease. And what that contact means can change depending on the disease itself. So we have diseases that are transmitted through droplets in the air from the respiratory system. We have diseases that are transmitted through fecal oral route, where somebody's poop contaminates somebody's food. We have diseases where they're bloodborne, where if you get something into your blood, then they can transmit that way. We have sexually transmitted diseases, where if you have sex with someone who has the disease, you can catch it that way. So contact can mean different things for different diseases, but a healthy person has to come in contact with a sick person. And then from that contact, the sick person has to transmit germs to the healthy person. So that doesn't always happen, right? You can meet a sick person and not catch the disease from them, but you do have to meet them before you could catch the disease from them. And then from there, if you've had contact with a sick person and the sick person has transmitted germs to you as a healthy person, then you can go on to develop symptoms and become a sick person yourself. Okay, so put together, that means we needed to have contact between sick people and healthy people, and we needed to have transmission of the germs from the sick person to the healthy person. So together, this is going to give us a rate at which healthy people become sick people. So let's just call that rate 1, and we're going to put that in the back of our minds for a minute and just leave it there for later. All right, so now what happens to infectious people, right? Those were the two categories of people we had. We had healthy people and we had infectious people. So what happens to infectious people? It's actually even simpler than what happens to healthy people. Sick people have two options. They can recover from being sick and go back to being healthy people. And sometimes they can have immunity, so they can't catch the disease again. We're going to make that assumption today. We're going to assume that when you recover, you have immunity and can't catch the disease again. Or they could die. Dying is bad. But both of those things, because they're happening without the need for an external contact or an external behavior, both of those things are a rate. So we could have a rate of recovery and a rate of death. Death is depressing. Let's ignore death for today. We're just going to talk about a rate of recovering and developing immunity so that they can't catch the disease again. All right.
You know, folks have said you can put your video back on. They'd like to see you.
Okay, I will try it. All right, someone please tell me again if I stop being audible. But okay, so now we've ignored death. So that's always, that's a thing that empiricists never get to do. Modelers get to do this all the time if we want to. Death no longer exists. We just have sick people recovering to be healthy people, and we're going to call this rate 2. So we had rate 1, which is the rate of healthy people becoming sick people. And that was a process that came out of contact and transmission. And then we have rate 2, which is sick people becoming healthy people, right? So that's the logic of our system. let's put it all together. If we write it down all in the same loop, instead of making two different arrows between the pairs of categories of people, now we have this progression. We have healthy people who at some rate 1 become sick people, who at some rate 2 become healthy immune people. That's the abstract logic of our disease system. So we can write it down even without the pictures. It's the same thing. We can write it down and say susceptible healthy people at rate 1. I don't know if you guys can see my cursor. Can you? I'm going to assume yes. Become infected people. Infected people at rate 2 become recovered people. So we have 3 boxes of people. Susceptibles, S, infected, I, recovered, R. And we have the 2 rates, rate 1 and rate 2. All right, so now that was the first step. As modelers, we've now done our first step together. We've taken a real world system and we've done good storytelling to ourselves and figured out which elements of the story were really important for us to figure out. And now that we've told our story, now we're going to take that logic and turn it into equations so that now we can deal with it quantitatively, not just qualitatively. So what does this mean? Let's ask, okay, susceptible people. How many susceptible people should there be tomorrow? Well, that's really easy given the logic of our story. We can ask how many susceptible people are there today? And that presumably we can look around the world and know. Let's pretend we're really good at measuring that. So we can just know today how many people are susceptible. But then how do we calculate how many people should be susceptible tomorrow? Well, given our story, given our logic, we know that the only way that you can not be a susceptible person tomorrow if you're a susceptible person today is if you catch the disease from an infected person. So for every susceptible person, you have to ask, what's the probability that you contact and then catch the disease from every possible infected person? So if you think for a moment about how that counting works, it's every susceptible person could meet every infected person. That's multiplication. So the number of susceptible people times the number of infected people times that rate at which that contact leads and transmission leads to the susceptible people becoming infected. That's how many people we should take away from our group of susceptible people for tomorrow, right? So that's all that's happening. We're going to remove susceptible people at that rate, given that the people they'd have to contact from that rate are the infectious people. So how many susceptible people tomorrow? It's the susceptible people today minus rate 1 times the susceptible people today times the infected people today. And that will tell us how many people are susceptible tomorrow. What about the infectious people? How many infectious people will we have tomorrow? Well, we can do the same kind of logic. We can say, how many infectious people were there today? That's where we start. And then we need to add into those infectious people everybody who we just said caught the disease and was leaving the susceptible category. All of those people have only one place to go. They left being susceptible because they caught the disease and therefore move into the infected class. So we're going to add those people. So it's exactly the same logic and set of numbers being multiplied together. We just move that. Now we're adding instead of subtracting. But not everyone who's infected today or who gets added in will still be infectious tomorrow because they might recover. And they recover, remember, at that rate too. So we're going to multiply that rate 2 by the number of infected people today. That's going to be how many people recover today. And so they won't be infected tomorrow. So we're going to subtract that number from the number that are infected today. And when we put it all together, that should be the number of people who are infected tomorrow, right? It's the number of people infected today, plus the number of people who caught the infection today and stopped being susceptible, plus the number of infected people who recover today and become recovered and immune tomorrow. So it's just that simple. And tomorrow, how many recovered people will there be? Even simpler, it's the recovered people today, plus all those people who recovered from being infected today. So in exactly the same way as for susceptibles, we were subtracting a number and that number showed up as being added to the infected people, When we subtract from the infected people because they recovered, we just add exactly those people into the recovered population. And there we go. That's the equation for the logic of the recovered class. So now together, all three of them, we have the complete set of equations to describe our logic together for the storytelling of what happens in an infectious disease outbreak. All we need are those three equations. It's really simple. It seems really straightforward. So now the question is it useful? Have we learned something through our storytelling that we didn't know before we started telling the story? Right? So if you think back to some of the most beautiful fables or passages in great literature or parables in the Bible, the answer is we all knew the elements of those stories to start with. We knew that those pieces existed, but somehow the act of putting the story together and telling it to ourselves highlights a useful insight that we didn't necessarily internalize until we told that story really well. So has this storytelling with these equations, has it allowed us to gain insight in the same way that a really good fable has a really good moral, that yes, we knew, but now we actually internalize it and can say to each other, yes, this is the way it is. Okay, so let's go back to the question we talked about a few minutes ago, which is, why do outbreaks end? So what does it mean for an outbreak to end? At its most basic logic, an outbreak ending is a pattern where the number of infectious people starts going up, but at some point it stops going up and it starts going down, right? That's all it means for an outbreak to end. It's gonna go up and go down. So can we ask that question, why do outbreaks end, given the storytelling and equations that we just built? Well, first thing to notice is that this is really only a set of questions about the pattern for just the infectious people, right? When we talk about an outbreak curve, when we talk about an epidemic, we're talking about how many people have the infection over time. So in the three equations that we just built, we really only need to talk about the equation for the infectious people. That's convenient. So we have three very simple equations, and now we really only have to think about one of them. So remember that the equation for the infectious people for tomorrow was the number of infectious people today, plus the new people who caught the disease from being susceptible today, who met an infected person and then at rate 1 caught the disease, minus the people who were infected today and they recovered and became immune tomorrow. So we can ask ourselves, well, when is that increasing? Because the pattern was right. First, the infections increase and then they decrease. So when is it increasing? What does it mean for I tomorrow to be increasing? It means that I tomorrow has to be bigger than I today. And for that to be true in this equation, we need the piece that we add, the green piece, the rate 1 times the susceptibles today times the infected today. That piece has to be bigger than the blue piece that we're subtracting, the recovered people. That was rate 2 times the infected people today. That's all that means, right? We're starting with a number, and in order for the number tomorrow to be bigger, we have to add more than we subtract. That's all. So that's a wonderful insight, because it's about to let us do something profoundly beautiful. Again, we're just rewriting it using a little bit of adding to both sides of the equation. So we add rate 2 times I today to both sides of the inequality, and we get rate 1 today times I today times S today has to be bigger than rate 2 times I today. And if that happens, then I is increasing. Okay, but now let's go back to our susceptible equation, because notice that, I skipped a step and I shouldn't have, I'm sorry. I canceled out I today from both sides of the equation. So we were multiplying both sides of the equation by I today. So we can divide both sides of the equation by I today. So that can drop out of both sides. And all we get is that the rate 1 times the number of susceptibles today needs to be bigger than rate 2. My apologies if I screwed everyone up on that one, but hopefully you're all with me. All right, so we now know I is increasing when rate 1 times S today is bigger than rate 2. So now we go back and go, okay, well, rate 1 and rate 2 in our simple model aren't changing, but S today is changing. And so what is S today doing? As today becomes tomorrow, becomes the day after, becomes the day after, each day when we calculate how big is S tomorrow going to be, what we're doing is going back to the equation we wrote, S tomorrow equals S today minus the number of people who catch the infection. So that number, S tomorrow, is always at most S today. It has to be either the same as S today or less. And if there are any infected people in the population infecting the susceptible people, then that number is going down. S can only be decreasing if it's moving at all. If that's true, and S keeps decreasing, then at some point, rate 1 times S today, as S gets really small, is going to stop being bigger than rate 2. And it could happen only when we have no susceptible people left. Then that side of the equation would become 0, and we know rate 2 is bigger than 0. But it could happen before then. If rate 2 is big enough that rate 1 times some non-zero number is still going to be smaller than rate 2, then we no longer have the condition that was necessary for I to be increasing. That means that I has to start decreasing. That means that we have to get this kind of picture for the outbreak of infectious people over time. We have to have, if I is increasing, as I increases, it's increasing because it's decreasing the susceptible population. The susceptible population, as it shrinks, makes it less and less likely that I can keep increasing. And at some point, I will stop increasing because it succeeded at depleting its own resource of susceptible people. We have to get this peak picture that's self-limiting. So that's an incredibly powerful thing. This is also how we compare outbreaks. So right now, what we've done is to prove to ourselves that if we have a disease that you catch from each other, if we have an infectious disease that generates immunity, that we have to have any outbreak will eventually die out in the population. And we did it by looking at whether or not rate 1 times S today is bigger than rate 2. Instead of subtracting or comparing, we could actually also divide, and that gives us a ratio. That tells us whether or not rate 1 times S today divided by rate 2 is bigger than 1. That's an equivalent mathematical statement, right? That's arithmetic that tells us, is the disease increasing? If not, the disease is going to hold steady if it's equal to 1, or decrease if it's less than 1. So that gives us a threshold test, just that ratio. If we can calculate that ratio for a disease with the population of susceptible people today, that will tell us if that disease should cause an outbreak. That ratio is also what is called R0, which is the reproductive number for the disease. It approximates, it describes how many new infections each infection causes. It's kind of like thinking about how many babies each disease gets to have. So if I'm a disease that's kind of like a bunny, and bunnies have lots and lots of babies, then my R0 should be really big, right? I should be able to have that ratio be much bigger than 1, because the rate at which I'm converting susceptible people to infectious people is very large relative to the rate at which the infectious people are recovering. If instead I'm more like an elephant and I maybe have 1 baby, and if I'm lucky 2 every 2 years or so, then that can still be increasing. I can still have an outbreak, but it should be a very slow outbreak, right? We can have a growing population of elephants, but we can't have a growing population of elephants that surprises us and overruns the globe by tomorrow. It takes elephants too long to have babies. So in some sense, this ratio that we got from these really simple equations is a metric of how quickly a disease can overpopulate, or overpopulate's the wrong word, can just populate, how quickly the population can grow of the disease itself. The bigger the R0 is for the disease, the faster it spreads and the worse the outbreak is going to be. But of course, also, as it spreads faster, what it's doing is eating up the susceptible population into the infected category faster. and coming closer and closer to that point where rate 1 times susceptible today will not be greater than rate 2. And at that point, the outbreak will start to go away. So here are some R0 values for some of our favorite diseases. And I shamelessly copied this from Wikipedia, but Wikipedia was pretty accurate in all the ones I knew about, so I'm going with it. Measles has a gigantic R0. We think that every case of measles generates somewhere between 12 and 18 new cases of measles if everybody is susceptible, if there aren't either vaccinated or immune people in the population already. Smallpox, about 3.5 to 6. AIDS, 2 to 5-ish. We think coronavirus, the current pandemic, is somewhere between 1.4 and 3.9. We're working on better estimates for that. Yeah, the 1918 influenza pandemic, estimates are between 1.4 and 2.8. The Ebola outbreak in 2014, somewhere between 1.5 and 2.5. And annual seasonal influenza in the United States that happens every year, we think it's somewhere between 0.9 and 2.1. Now notice that R0 is a really great way to describe how infectious a disease is going to be and how much it's going to cause an outbreak, but it doesn't necessarily tell us how much to worry about that disease, because we can have a really big R0 for a disease that doesn't make you very sick. And similarly, we can have a really low R0, as long as it's over 1, we can have a low R0 that we're still worried about, because even though the outbreak would grow slowly, a lot of people could be made very sick or die from it. So we really worry about the combination of the outbreak and the severity of the morbidity and mortality from the disease. How sick does it make you and how likely is it to kill you? Okay, but we know that diseases don't just go away permanently, even for diseases that generate permanent immunity. So we just proved to ourselves that diseases should go away, outbreaks should go away. As long as they generate immunity, outbreaks should go away. But we know that that's not the whole story. So what's going on? Right? Our storytelling was really great to give us some insight, but it clearly wasn't the whole picture that we had to tell the story about in the real world. So here are some real world graphs of diseases over time. So measles in China, and you can see that there are these beautiful outbreak curves, and each one goes back down, but it doesn't stay gone. And these are simply sequential years of measles in China. So no one has lost a lot of immunity to measles after they got it 1 year later. They still have immunity. So what's happening? Annual flu outbreaks. There is a mutation in flu strain, but even if there wasn't, we would expect that there should be some periodic outbreak of influenza. Rotavirus, global pandemics of flu. We can ask ourselves, what are we missing, right? Why did these not just go away? And the answer is babies. Babies get born after the disease comes through and don't have immunity. But when the first few babies are born, everybody around them has immunity. And so the number of susceptible people as a percentage of the population, if the new susceptible people are just the babies, that's not enough yet for there to be an outbreak, because we just don't have babies that fast. We have babies pretty fast, but not so fast that we're replenishing a whole susceptible population. So what happens is that babies gradually creep back up in that susceptible population. So when we go back into our calculation for how many susceptible people will there be tomorrow, instead of just having a subtracted thing that we take away when you catch the disease, now we're also adding back in some rate of the production of babies. That means that at some point after the disease has died out, because rate 1 times S today is not bigger than rate 2, at some point it's going to be bigger than rate 2 again, because S tomorrow is gradually increasing because we keep on adding in those babies. And we haven't been subtracting out the too many people catching the disease because there isn't an outbreak right now. So even if a couple of people are getting the disease all the time, maintaining some infection in the population, the reproductive number of the disease is not going to be too big enough to cause a big outbreak until we have enough babies. and then we get an outbreak. We can also talk in the same way about people losing immunity over time. Not all diseases cause immunity that lasts the rest of your life. So it's a little bit of a lie to say that it's just babies, but it's mostly babies. So, all right, this is also how we talk about and how we figure out how many people need to be vaccinated in a vaccine campaign in order to help stop an outbreak. So vaccines are always helpful, or we wouldn't authorize their use for the individual person to protect against either catching the disease, or some vaccines are not great at making sure you don't catch the disease, but they're really good at making sure you don't die from the disease if you catch it. Both of those things, they're good at personal protection. But there is going to be a point where we could vaccinate enough people in the population who are susceptible and simply take them out of the susceptible class without them having to catch the infection. That means that rate 1 times the susceptible class will not be bigger than rate 2. If we can vaccinate enough people to keep that number of people in the susceptible class low enough that rate 1 times the susceptible class is not bigger than rate 2, then there should not be an outbreak. That's when, if you've heard in the news about the herd immunity effect or the herd immunity threshold, that's what that means. It's the idea that by most of the people in the population being immune, either because they've already caught the disease and are immune naturally, or because we've given them a vaccine and they've generated natural immunity based on the artificial introduction of the safe vaccine, then everyone else, even if they weren't vaccinated, or even if they're a baby that was just born, is protected because the outbreak can't happen. That's what the herd immunity threshold means. All right, so we have this incredibly simple, powerful model that has already told us why outbreaks end, how to decide whether or not a new disease is really dangerous, if it's going to be a spreadable outbreak or not, how quickly that outbreak should spread, how quickly that outbreak should end, and how many people we'd have to vaccinate to stop it. We did that all from this one incredibly simple story and these 3 incredibly simple equations. That is a beautiful and powerful example of mathematical modeling, and it's also really useful in keeping all of us healthy. So let's use it for a second to understand. There's been a hashtag that people have been circulating that's wonderful and so important, and it's been dubbed flatten the curve. Right? And we've hopefully all seen it at this point. And the idea is to take an outbreak curve where the peak is really tall and narrow and smush it down so the peak is lower and spread out. How do we know that we can do that? How do we know that that's a possible thing to do? Well, if we look back at our equations again, flattening the curve is all about rate 1. So first of all, let me back up for a second. Why do we want to flatten the curve? Well, there's the idea that the people who catch a disease need medical care, and that we can keep people from dying, even if they catch the disease, if we have enough medical staff and equipment. And we can keep medical professionals from catching the disease if they have enough equipment and if they can get sleep between dealing with patients. And then also, in addition to the people who catch the disease itself and need medical support, there are all of the people who don't have this disease, but still need doctors in order to be healthy and maybe not die from all of the other things that constantly cause us to have to seek out medical professionals, having heart attacks, catching other dangerous diseases that are the current outbreak, getting a cut that needs stitches, all of those things. If we have too many sick people at once and the healthcare system can't deal with them, the healthcare system can't deal with any of us well. So what we want to do is try and flatten the curve enough that we don't exceed the capacity of our healthcare system to deal with sick people, whether because of the disease or because of the disease and all the other things we normally use healthcare for. So now let's go back and say, okay, flattening the curve, great, we're all on board. We want to keep everybody alive. How do we affect rate 1? Rate 1 is going to be how quickly the outbreak increases and when does it run out of people to infect and how does it fall back down, right? All right, well, if we can slow down rate 1, that's what it means to flatten the curve. We move people out of S more slowly. The flatten the curve, right? Those are the I curves, the infected people curves. So we're moving people out of S more slowly into I more slowly. It's a more gradual transition. That means, of course, that because we're moving people out of S more slowly, that it takes longer to hit that point where it's going to change from the number of infectious people is increasing to the number of infectious people is decreasing. So we know that what we're doing is putting off when the worst part will be in order to keep the worst part not as bad. So how do we make this take longer? What do we do? Well, remember that rate 1 was a combination of contact and transmission. So here are the things that we do. If we don't have vaccines, if we don't have better technology, if we can't increase our healthcare capacity, so that's something else we do. We build triage hospitals. We put tents in Central Park, and we ask doctors to come from regions that aren't currently overwhelmed and help. And we ask for Federal Reserve ventilators and all sorts of things like that. But how do we as people influence the system? Now, we as mathematicians can go, I know, we have to reduce rate 1. We can reduce contact by social distancing, by physical distancing, making sure we don't come in contact with other people. And we can reduce transmission of germs given that contact if we practice better hygiene, washing our hands, not touching our faces, not hugging each other, not shaking hands. All of those things prevent transmission of germs given the number of people we're going to see. This is why these are policy recommendations. Social distancing is to limit the contact part of rate 1. Hygiene is to limit the transmission of germs part of rate 1. Because we know from the math that if we limit rate 1, we can flatten the curve. This is also how we can predict how effective our policies are when we say, please shelter in place, but you still need to go buy groceries. We can estimate, okay, how much did we reduce contact? How long do we need to continue sheltering with that reduced contact so that there aren't a lot of infectious people and we can get a handle on going in and medically intervening for the rest of them? What percent of people have to shelter in place in order to get rate 1 with the new modifications, so sort of rate 1 star? Rate 1 star times S today, not to be bigger than rate 2. How do we stop an epidemic? By changing rate 1 by personal behavior. So it can feel really silly to have a pandemic where we're scared about lots of people dying and have your doctors say, have your public health officials say, have your political leaders come to you and say, everyone please stay home and wash your hands. Because it doesn't feel like we're taking a huge action. It feels like we're being asked to do these trivial minor things. But we have now used math together to show that these are not trivial or minor. These are the things that we have in our power that can meaningfully slow down an epidemic. We have proven that these things that feel tiny are in fact gigantic steps as long as we can all do them together, because that is how we change rate 1 for the whole population. And that is how we save people from dying because our healthcare system is overwhelmed. So we just told a really simple, elegant story. And of course, not all of the answers for pandemic preparedness and response can be told this easily. So usually when we do the math, instead of asking about tomorrow versus today, we ask really more about continuous averages. We ask ourselves an instantaneous rate of change. What's happening in the next moment? And what happens if the next moment is even closer than that? Many diseases are also logically more complicated than just an infected person meets a susceptible person. So of course, we can transmit diseases in different ways. If an insect needs to bite needs to bite an infected person and then a susceptible person, that's more complicated than just 2 people meeting. If they have to have sex with each other, also more complicated than just 2 people meeting, because you can meet lots of people passively and cough on them, but most people hopefully are making active decisions to have sex with each other. We can contaminate an environment where I cough droplets onto a surface and then someone else touches that surface later and picks those droplets up. That's again a little more complicated than just an infected person has to meet a susceptible person and transmit germs. There can be mother to fetus transmission, where if a baby is being carried in a mother's womb and she catches the disease, she can give it to her baby. And when her baby is born, her baby will still have it. All of those change the dynamics a little bit. Of course, also there can be delay between being infected and becoming infectious. So I've caught the disease, but I can't transmit it yet to other people. That changes the dynamics a little bit of our story also. Immunity can go away over time. How long it lasts depends on the type of disease and the health of the person and the age of the person. We can have age-based differences. We see that right now with coronavirus, where older people are having more severe outcomes and are maybe more susceptible to catching the disease. We're not sure. We're learning. There can be seasonal and climatological differences. Some diseases survive better at particular temperatures or humidities. And of course, also there are opportunistic infections where the disease is actually not great at infecting you unless you have another disease. So tuberculosis in patients who have uncontrolled AIDS. There are all sorts of infections where if you're already fighting one bug, it makes it easier to catch another. All of those things are additional complexity that we could add to the storytelling that we just did, but we would analyze them in the same way. So the stories can get arbitrarily complicated. And here is just a diagram. So before we had 3 boxes and 2 arrows. Here is a diagram of all of the boxes and arrows from a recent paper that my students and I just did on tuberculosis in AIDS patients. And this was actually just an abstraction of, I think, one of the possible sets of diagrams from that paper. And here is just the first 12 out of the 40 equations from that paper. But, and I don't recommend that you look through these carefully, but if you did, what you would see is that each of these things is simply a slightly more complicated way of doing exactly what we did, of subtracting the infected people from the susceptible class and adding them into the infected class, or moving the infected people into the recovered class. And it was just a more complicated mechanism of that storytelling, but it's all boiling down to that same logic that we just did. And then, of course, we can use our model to make predictions that compare interventions. So these are some different curves of projected numbers of infections, given different types of interventions we could have taken. This one was for a mosquito-borne disease. This was for Zika virus, looking at different types of control for mosquito populations and then how many infections they were likely to cause in people. So we can compare those predicted outcomes from these curves. So this is what we do. We can predict curves and we can use theoretical thresholds to understand mathematical epidemiology and provide critical tools for pandemic preparedness and response. And it's really just that simple. Thank you so much for your participation. I'm happy to take some questions.
Nina, thank you very much. There are a whole host of questions, and since people have been voting for them, I'm going to start at the top of the list. And the top of the list is, how are rates 1 and 2 estimated typically, especially when we have a new disease outbreak? Could be hard to estimate those numbers from the available data.
Absolutely, what a great question. Okay, so we're going to start with the easiest and then go to the most complicated. The easiest one to estimate is actually rate 2. Because when we have some sick people, and this is again going to be with our simple SIR model, the one we just had with the susceptibles, infected, and recovered. It gets harder with more complexity. But with that model, our infected people were infectious and so basically symptomatic. We could tell that they were sick. So we can watch those people medically. How long does it take for them to recover? That's actually going to tell us the rate. We can approximate the rate of recovery by the relationship of 1 over the duration of their illness is about how many people on average recover each day from that class. And that's only really true at stability, but it's a good approximation. And stability is a good description of the disease itself as an inherent property. So about how long are you sick? About 1 over that is going to be about the average rate of recovery. Okay, now we get to something a little trickier. Believe it or not, the next easiest one to estimate is usually R naught, not rate 1. R naught can be estimated by trying to look at how many new infected people there are tomorrow relative to today. And that rate of increase should be exactly that ratio of rate 1 times the susceptible people from today looking towards tomorrow over rate 2, which we just measured from sick people. So we can estimate that ratio by looking at that initial incidence curve. And we do, I didn't say this out loud, it was on the slide, I should have said it out loud. R naught really is only an accurate estimate, the way we talk about it, at the beginning of an outbreak. When we start having fewer and fewer susceptible people and that ratio changes, we are no longer talking about R naught. We can talk about things like effective R naught or modifications to mean, no, what's the disease doing today? But it's not the what is the outbreak capacity of the disease? That's a good way to say it. What is the outbreak capacity inherent in this disease as a type of disease is predicated on there being the most susceptible people. So we can fit R naught to the incidence curve that we see at the start of an outbreak, and we can measure rate 2. And from that, of course, now we have 2 of the 3 unknowns in an equation, and we can solve for the third. And that's how we estimate rate 1 most of the time.
Thank you, Nina. That was a great explanation. The second question that has moved up on the queue is, once social distancing is over, won't there be a peak again? Not as large, perhaps, but still a big peak nonetheless.
Awesome question. So the answer is, if nothing else in the world changes, yes, probably, because we aren't, so caveat, let's do a hyperbolic, really optimistic scenario first. Social distancing is so good that nobody comes in contact with anybody else for the whole duration of infectivity of the disease. In that case, the disease dies out completely. So no, when we stop doing social distancing in that case and come back together, there shouldn't be a new outbreak because there are no infectious people in the population to get any new susceptible people sick. But we know that we're not going to be that good at social distancing. So what we're doing is not hoping that the disease just completely dies out. So in that case, you're right. If nothing else in the world changed and we just all mushed back together into our normal social interactions and infected each other, yes, there would be a second peak. And the only reason it wouldn't be as big as the peak we're worried about now is literally that some people would already have caught the disease. And so they would be buffering a little bit. They'd be slowing down a little bit how easy it is to meet a new susceptible person if you're an infected person. But there's a critical but here. Part of what we're doing also is buying time to figure out which interventions medically support. So right now there are a zillion parallel studies for which medicines might actually help you survive the infection better. We don't know yet. We might have some. There are some promising drugs that people are trying now, but we don't know which ones are actually helping. We have some suspicions, but no evidence. We have some anecdotes, but no actual concrete trials to tell us. There are people working on a vaccine, and if we can wait long enough for a vaccine to be developed and distributed, that will also help. And then honestly also, we might be able to accept having tiny periodic outbreaks as long as we don't overwhelm the medical capacity. I don't know if I personally believe the data out of China in all of its glory, but towards the end of the outbreak in China, the case fatality rate for even just the people who developed symptoms, so we're not even talking about asymptomatic disease for coronavirus, even just the people who developed symptoms, the case fatality rate towards the end of the outbreak was 0.7% instead of during the height of that outbreak, which was 5.6%. That's a gigantic number of lives saved. And that's because they had access to all of the medical equipment and staff that they needed to support those patients. So it might be that we actually accept the same way that we accept annual flu outbreaks, but we don't worry about them too much because medicine can always handle them. What we might do for a little while is social distance in order to make sure that we don't exceed the healthcare threshold, wait for the disease to die back down, stop social distancing, relax it a little bit, not rush back into like, don't French kiss strangers, but let it go grow a little bit again, and then institute social distancing again to just constantly keep it underneath where our healthcare system is overwhelmed until we get better drugs, better medical practices that everyone knows, have more protective equipment for our doctors, have more ventilators, have more of those life-saving treatments. So for coronavirus specifically, there are really good reasons to try and flatten the curve. And then the more people have some immunity, the more that will happen naturally and become maybe periodic outbreaks, but no outbreak that overwhelms healthcare.
Nina, that was a really great and thorough explanation. The next question is about how the R0 computed for COVID-19 is different. Why is it higher or lower than some of the other coronaviruses? Do we know much about the sort of ecology of interaction?
So okay. This question has a bunch of parts. So the first one is, why is it higher or lower than other coronaviruses? That by itself is a great virology question. So the study of viruses itself tells us that different viral genomes, different members of a family. So the same way that you and your siblings, those of you who have siblings on this webinar, you have a lot of DNA in common with your siblings, but you don't behave the same way. There are probably meaningful personality differences between you and each of your siblings. And even if you have quite a few things in common and you all grew up in the same home and you share a lot of your DNA, you, by having a little bit of a different DNA and a little bit of a different experience, have really different behaviors. And so in a very real sense, coronaviruses are a family of viruses. And this is a new cousin. And this new cousin has its own behavior in terms of its transmissibility and how sick it makes people. Both of those things are different. So we know we have some very transmissible coronaviruses that don't make people very sick at all. There are coronaviruses that cause what we think of as the common cold. It's not the only thing that causes the common cold. It's also rhinoviruses, but still, colds. We don't worry about those really at all. And some of those are coronaviruses, but those are a cousin of the current coronavirus. They're also really deadly coronaviruses. So MERS, really deadly, Middle East Respiratory Syndrome. SARS, again, cousins of the current coronavirus, also coronaviruses, but different profile. So if we want to talk about why each of them has a different R0 calculation, it really does boil down essentially to the slight differences in the viral genome, even though they're all coronaviruses. But then also, there is an ecology of this that suggests that diseases over time experience evolutionary selective pressures that should make them less deadly to their hosts, because we're the houses they live in. And if they're constantly destroying their houses, they have fewer and fewer houses. But this coronavirus is completely new. It hasn't essentially learned to stop destroying its house, and it may not. The nice thing about evolution is that it's so random, but unfortunately in this case, the bad thing about evolution is it's so random. If it doesn't have a random mutation that says, maybe don't kill people so much, then that won't be around to be selected for. So there's a combination of sort of the ecology and evolution part, but then also just different family members have different behaviors.
Great. And I really appreciate you bringing up the E word there, evolution, which
of course,
which we need to make sure that people understand that these things are not static entities.
No.
How the viruses arise.
It's going to make our lives both harder and easier, because if it's a moving target. So, yay.
So the next question here, I think, relates to something that I know that you've been spending a lot of time on, particularly recently. So the traditional dissemination system for new research, that's peer review and publication, seems to be really inadequately slow for the current situation. What are efficient ways to share new results, potentially useful for the community, especially when local administration may or may not believe in mathematical modeling, not just local administration. But you've been dealing with this with people all over the world recently. Do you want to say something about how it's working?
Absolutely. So this is one of those things that I think is both amazing and terrifying at the same time, about how the global response in the scientific community has been to coronavirus. So it's not just mathematical modelers. Now I'm going to talk about scientists in general and mathematicians who are participating in this. All of us right now have basically thrown out peer review. We're still submitting our papers to journals, but that's not the meaningful mode of communication that we have with each other. Right now, basically all of us are uploading our papers to the web on medRxiv or bioRxiv, which are public repositories. It's kind of like Wikipedia, but instead of editing each other's papers, we're just all like, basically we're all throwing up a web page being like, here's all my research. The nice thing about the way those two sites are organized is you can cite each other as though it's a paper. So the wonderful thing about that is that it's instantaneous. And we've seen, you can look in the news, there are papers that have not been through peer review, but have been just basically shared on a website that are informing policy right now because people think they're good models. The downside is that there are also papers that get thrown up on the website without peer review that are not great models and that could be improved with a little bit of collaboration. And that's what arXiv is letting us do. That's what the bioRxiv or medRxiv are letting us do. They're letting us communicate with each other in real time to learn from each other and improve and make better papers and put those up and then make those recommendations public and immediately accessible to doctors and policymakers. But it also means that there's a lot of noise. There's much, much, much more noise in the signal than we've ever had before. So it's brilliant in that we are not being time limited by the process of peer review and publication and journal editing and all of the things that we normally get annoyed about slowing us down as researchers. It's brilliant to get rid of those. It's also incredibly scary to get rid of those because I don't know about you guys, but I am not perfect. And I love relying on colleague experts to help make sure that I don't make fundamental mistakes, especially when what I'm trying to do is make recommendations to change people's lives. If I'm trying to make sure, if I tell a hospital, go do this because it will save lives, and I've made a sign error, I might kill people. I don't really like the idea that my paper is just out there and now people are trying to act on it. So hopefully we're going to converge, and we have been trying to. You can watch the community try and converge well. It's even noisier though, and this is not a bad thing, this is a good thing. It's even noisier because we also now have kind of armchair epidemiologists showing up, which is wonderful because there are smart people who are not epidemiologists and they have things to contribute. But they're also making some mistakes that we as a field of experts know we probably shouldn't make. But those papers don't look any different from the papers of the experts. And so sifting through, there's even more. I mean, some of it's brilliant. Some of these are ideas that we need, that we, by being experts in the field, wouldn't think of because they're outside of our box. But it's going to take a little bit to shake out and see exactly how well we can deal with the sort of floodgates opening. And I think it's a wonderful new mode for this rapid response, but we're not, I don't think we're going to ultimately converge on this as the new way we do science. I think we're going to gradually figure out a good balancing act.
Great. Thanks so much. Several people have posted the links to the archives in the chat boxes, if you'd like to take a look there.
Awesome.
Here's another question. One of the big issues in our current situation is that we do not know the number of infected because of lack of testing. Can we form an enhanced model with number of infected and number recorded infected with the number of test kits as a variable, and then study how the number of test kits impacts the outbreak?
I want to know who wrote that question.
It was Christopher Jones.
Oh, yay you. Okay, this is going to sound egomaniacal on my part, but I have a paper on medRxiv right now on exactly that. So quite literally, if you go to medRxiv and look for papers by me, there's only one there right now, and it is exactly how to alter these kinds of equations that we just talked about in this webinar to include lack of access to testing, different access to testing over different times of the outbreak, and different certainties in how accurate our tests are over time. That's literally research I've done. I don't know if you just seeded that question because you wanted me to love you, but thank you.
Okay. This is, I think, more of a general modeling question. With zillions of factors, as you put it, how do you measure and sort of instill confidence that you haven't overlooked something significant in your model?
That's an awesome question. These are all really great questions. Okay, so the answer is that modeling is an iterative process. So even though I just walked us through as though it was really linear, as though we have like a clear story, and then as soon as we tell it, we get clear insights and we know that we're right. What we actually do is take that logical abstraction from the system, and then we make our equations from it, and then we make our predictions from those equations, and then we go back to the measurements from the real world and we go, can we predict it just from the logic? If we didn't know anything but the logical story that we just told, could we make good predictions? Could we have said, oh yeah, this one should be worse than that one because it takes more time to recover? Can we make those predictions? Are they both qualitatively in agreement, and in some cases even are they quantitatively in agreement with the predictions of our models? And in some cases the answers are no, we're wildly off, we've missed something. And in the cases where we agree, even then, that's evidence that we might not have missed something, but there are all sorts of reasons why something might turn out to be the number 7. And so what we try and do, the same way that empiricists replicate studies, we try and find different sources of observations to check our predictions against in the real world, to see whether or not all of the aspects of things we could predict and all of the insights that we tried to gain from our system are consistent with the types of observations we can make in the real world. And the more different types of observations we can make accurately, we can predict accurately and match to those observations with our models, the more confidence we have that we haven't really missed anything too bad.
Great. That's basically a whole course we could do.
Yeah.
This question. Here's a question that you touched on, and there were several responses to. I thought I'd ask you to comment on it. Is rate 1 always a constant? How do you deal with the dynamics of the rates themselves?
Awesome question. So again, no. So in isolation, in an idealized perfect world where we're just talking about a system to study, then rate 1 would be a constant. But of course it's not. And there are lots of reasons why it's not. The most fundamental biologically is evolution of the pathogen. So as it infects people, it's also changing. Hopefully that's pretty slow relative to the outbreak itself, but not always. One of the really, really challenging things about HIV is that it mutates so quickly in the host as it transmits. Luckily, we don't think we're in that case for coronavirus at the moment. But there are all sorts of other reasons why rate 1 could change. For example, in the middle of the outbreak, we institute social distancing. Or in the middle of the outbreak, people get scared and start washing their hands. Or in the middle of the outbreak, people decide to be kind of weird and throw parties to get each other sick because I don't know. But that's a thing apparently that the young people are doing these days. So please don't do that. So these are all things. Or again, we might be able to get a vaccine that only partially protects people, where you could still catch the disease, but the probability of successful transmission of germs is way lower. All of those things would change in real time over the course of an outbreak. And so we can, instead of thinking of them as a constant, we can also think of them as a variable for which there is an equation that tells us how they change. And that also is actually some work that I work on, but a lot of people work on that question also. It's a rich and beautiful set of questions.
Great. Here's a question about face masks. I don't know if you have an opinion about it, but with the current outbreak, what's your take about using face masks to basically decrease the rate of infection?
Okay, so this one's a dangerous question because the wrong answer to this is going to get people killed. So in an ideal world, everyone would have a face mask and use it well. But we are not in an ideal world. So things we know. Face masks are much better at preventing sick people from transmitting to infected people than they are at blocking susceptible people from catching the disease from infected people. So they're reasonably good at protecting susceptible people when you put them on a sick person. They're less good at protecting susceptible people when you put them on a susceptible person, but that doesn't mean that they're useless. They are still an interruption in breathing in virus particles. But there are two big buts to this. The first one is most people are not used to wearing face masks. And if they don't fit well, what that actually causes you to do is fumble with your face a lot. And the last thing you want to do if you're using a mask to cause you to feel more protected in the world is to touch a lot of surfaces that could have virus and then mush them into your face where all of the orifices connected directly to your respiratory system are. So if you're wearing a mask that you're adjusting close to your eyes, close to your nose, close to your mouth, that's dangerous. But let's assume for a second that everyone has really good behavior and puts on their mask and then doesn't futz with it. Right now, please still don't do that, even though, yes, it would probably help. The answer why not is that we do not have enough masks, globally or nationally or locally. None of the world does. We were not prepared for coronavirus to be a pandemic. We do not have enough masks. This is a giant problem. And way more than we are worried about individuals catching coronavirus, we are desperately worried that we will run out of medical staff. All of us have a better chance of surviving all of this, even given catching it. The decreased risk that you have of catching coronavirus as a susceptible person wearing a mask, even though that mask would offer you some protection, the decrease in your risk that that mask might offer you is not as effective as the increase in your safety if you are guaranteed to have healthy medical staff to take care of you if you get sick. So right now, regardless of whether or not in an ideal world everyone would wear a mask and interrupt transmission, because there are susceptible people who could block transmission, and even more so, there are asymptomatic infected people who are going to develop symptoms or not, who are transmitting. We know that infected people who don't yet have symptoms can transmit this virus. And it would be great for them to be wearing a mask just because and interrupt their transmission of the virus because they're wearing a mask. But even though all of those things are true, if you are a member of the general public right now, please do not use up a medical mask. If you want to rig a mask that you make yourself out of something else and that makes you feel more protected, don't futz with it when it's on your face, and do wash it and clean it and wash your hands. But go ahead for that. It's not a terrible idea, but please do not use medical masks. Right now, we need medical practitioners to have all of the ones we've got.
Nina, thanks so much. I know that you have to go off soon to be interviewed for a podcast.
I do. It's a weird world.
Do you think you have time for one more?
Sure.
Okay. There's a whole host of them here, and there are many, many good ones. How complicated is the model that public health officials are using right now to predict how many days we should practice social distancing? Do they use network models, differential equation models? Do you know what's being used?
So I know some of what's being used. So there's a suite of influential models right now that are being discussed at the highest levels. There are a diversity of techniques being used in those. Some of them are more broadly considered at all levels than others, which is not always a good thing. So for example, there's a lot of talk right now in the administration in the United States and in Great Britain about a model that came out of Imperial, out of Neil Ferguson's group. That's, for the record, a tailored flu model that makes some really interesting assumptions, but it's still a valuable model to help gain insight. There are some networks models. There are some agent-based simulation models that were developed under the MIDAS, the Modeling of Infectious Diseases. Oh God, I'm going to script the end of that acronym, but the NIH, I'm sorry?
Yeah, and as agents.
As agent simulation, something. There's an S in there somewhere. But yeah, it doesn't matter. NIH funded some really great groups of modelers to be prepared for this. So all of their models are also being discussed. That has become since a broader community of modelers participating together. And of course, there are models at local levels. So my personal models have informed states at this point in some of the choices that they've made. Why they chose my model instead of someone else's, I honestly don't know. I have faith in my own modeling, so I'm not upset about it. I would love it if instead everyone was looking at the same suite of recommendations and comparing the outcomes. The real answer also is all of these models are being developed in real time and parameterized, excuse me, parameterized in real time with comparison to data that does keep changing. We don't actually have knowledge in the true sense of the word with a capital K. We have really, really good expert guesses, and those are changing, and those will get better over time. But right now, things like how long should we stay in social distancing, the answer is going to be, please let's keep trying to social distance as much as we can and see what effect we have on flattening the curve and make updated estimates about what that should do as we get that information.
Nina, I think that you've done a phenomenal job explaining these and responding to hosts of questions, and I know that we need to let you go. There are still a lot of questions here on the Q&A, and I will try to save them
Please.
and respond. Also, we will probably put up on the website a list of some texts, because there is a whole bunch of background and relatively lower level texts that people might find useful to take the next steps associated with this, to be able to understand some of those more complicated ODE models that you put up there.
Awesome. So yeah, I will try. So I have to confess, not only am I running off to be interviewed, but I am working on some practical questions to try and help inform policy to keep people safe. So I'm really overbooked at the moment, but I will try in the next couple of days to look with you, Lou, at some of the questions and maybe write up some quick answers to ones that got a lot of attention but didn't get answered during this. And maybe we can put some good answers up also.
Okay, great. So everyone, thank you very much for participating in this. We look forward to having you on future webcasts as well. And Nina, particularly want to thank you for all your time and attention and all the work that you're doing to help us get through this. So
my great pleasure. Thank you so much for hosting, and thanks to NIMBIOS for being such an amazing place to do this kind of research.
Okay, so just remind everyone, nimbios.org/webinars is the website to go to. So thanks a lot, Nina.
Thanks.
Bye, everyone.
Bye, guys.